Hello and welcome to another live broadcast with MedStar Health. My name is Mishan Bowman-Carter, and I'm joined today by a panel of our cardiac surgeons and interventional cardiologists. Today, we're recognizing #Valve Disease Day, which brings awareness to the fact that an estimated 11.6 million Americans have heart valve disease, and each year, around 25,000 people die from the disease. Fortunately, valve disease can be treated successfully in patients of all ages. And today, our panel of experts will talk about the risk factors, symptoms, and treatment options for heart valve disease. So tune in and keep watching. I'd like to introduce our panel. So I'll introduce cardiac surgeon, Dr. Brian Bethea, cardiac surgeon, Dr. Jeffrey Cohen, interventional cardiologist, Dr. Lowell Sattler, interventional cardiologist, Dr. Ron Waxman, and interventional cardiologist, Dr. John Wong. So thank you all again for joining us today and spending your time with us. We really appreciate it. First, I'd like to dive into a few of our questions. I'd like to start first with what is heart valve disease? Dr. Sattler, could you tell us about that?
Sure, of course. As all of you know, the heart is an organ that circulates blood throughout the body. In fact, it beats about 100,000 times per day and probably pushes between 2,000 gallons of blood throughout the system. It squeezes in a very coordinated fashion, and it allows the body to get nutrients. Between each of the heart chambers is a valve, and that's a thin piece of tissue that keeps the blood moving predominantly in one direction. Heart valve disease is when there's damage to one or more of the four heart valves that prevents them from opening and closing properly. While some types of disease are not serious, some of them can have major complications. So if the heart valve doesn't close completely and allows blood to leak backwards, it's called regurgitation. If the heart valve is narrowed and doesn't open properly, it's called stenosis and results in an obstruction. And so each of the heart valves can either have regurgitation or stenosis or both. And the two of the valves that we talk about most commonly, the aortic and mitral, are the ones that we see on a regular basis that have disease. And so what happens is that with either narrowing or leaking, the heart has to work a lot harder than it usually does. And eventually this causes symptoms resulting in heart failure and in some patients, death.
Thank you, Dr. Sattler, for explaining that. Could you also share who is at risk, who should definitely be on the lookout for heart valves?
So there are a couple of different groups at risk. Patients as they get older at risk because of the wear and tear of the valves opening and closing over a lifetime. Some patients are born with congenital abnormalities. They can have 2 leaflets rather than 3, and that can put wear and tear on a valve. Of course, if you have an infection and the valve gets infected, that can cause premature degeneration of the valve, either causing it to leak or get narrowed. Sometimes there's a family history of premature valve disease, and we see similar problems throughout the family tree. If you've had radiation to the chest and certain types of chemotherapy, that can cause damage to the valve leaflets directly or because of weakening of the heart muscle. Certain races, there's disparity because they may not have access to health care, and there's higher incidence of hypertension and renal failure, which is associated with valve disease. And then there are some more idiosyncratic diseases, connective tissue diseases that can be associated with deterioration of the valves.
Perfect, thank you. Thanks again, Dr. Sattler. So that leads me into my next question. So we know what heart valve disease is, who's at risk. Could you share how can it be prevented?
So it's easy, there are a lot of things that are genetic that you can't control, but there are some modifiable control factors, such as, eating healthy, physical activity, and very important, controlling blood pressure, diabetes, because these can have detrimental effects on the heart and ultimately result in early heart failure. course, once you have the diagnosis of disease, it doesn't need to be treated in everyone. It could just be monitored. Sometimes we use medications to slow the progression down. But when it gets worse, there are a lot of specific findings that we look for in determining whether or not more aggressive treatment is necessary.
Thank you. Dr. Bethea, I'd like to turn over to you now. Could you share what are the symptoms of heart valve disease? What are the signs that people should look out for?
Yeah, I think there's some stereotypical symptoms that go along with a lot of the different valves, specifically chest pain, potentially shortness of breath, and even the feeling of near passing out or passing out can all be related to a potential heart valve issue. What I find in elderly patients is there's more subtle signs because all of this is usually a very slow progression. So feeling tired, maybe you're taking more naps, or maybe the naps are slightly longer than what they used to be. And oftentimes we'll chalk that up to I'm just getting older. And that's not always true. And that's when you should probably seek your physician and let them know of those symptoms and see if there's any further investigation that needs to be warranted. Other really subtle signs are potentially feeling a feeling of fullness a little bit earlier, or just not being able to eat as much, swelling in the legs, swelling in your abdomen. All of these things can be related to potential heart valve disease and should be evaluated.
Thank you, Dr. Bethea. So once you know about those symptoms and you're aware that you could be, potentially could have heart valve disease, how do physicians make that diagnosis?
Yeah, we have a myriad of diagnostic tests that we use. I mean, the first is the stethoscope, which most of us don't use anymore, but it is available. And then from there, if they hear a murmur, then that usually triggers an echocardiogram. And based on the results of the echocardiogram, what Dr. Sattler was alluding to, depending on the severity of either the narrowing or the leakage of the valve, may trigger more sophisticated tests.
Great, thank you, Dr. Bethea. At this time, I would like to welcome our viewers again. Thank you very much for tuning in. Today, in honor of Valve Disease Day, we're talking all about heart valve disease, its risk factors, symptoms, and more. I'm here with our heart care experts, Dr. Brian Bethea, Dr. Jeffrey Cohen, Dr. Lowell Sattler, Dr. Ron Waxman, and Dr. John Long. We have more to talk about, so keep on watching. If you have any questions, please share them along the way. We're going to take some time to answer those as well. At this time, I'd like to share a comment that we received from Gail. So thank you very much, Gail, for tuning in and sharing this with us. Gail says she loves Dr. Sattler and Dr. Bernardo. And she says, I also must say their entire staff are superheroes, simply the best. My TAVR was almost 6 months ago, feeling amazing. So, you know, great job to all of you physicians and your entire heart care team for all of the wonderful work that you all do. Thank you very much. So thanks, Gail, again for that comment. Right now, I want to turn to Dr. Cohen. And let's talk about some of the treatments. So what are the treatment options for heart valve disease?
Sure. So I think first things first, whenever it comes to treatment for these things, I think it's important to point out that we always approach this as a team. You know, we have cardiologists, interventional cardiologists, and surgeons working together to determine, you know, really is the benefit of the treatment, does that outweigh any of the risk? I mean, even though these procedures are overall very, very safe, we still always need to make that calculation for the patient. With regard to the therapies that are available, there's a lot. You know, as you just alluded to, the TAVR procedure is one of the most common procedures that we perform together, and that's for patients with aortic stenosis, or when that aortic valve gets narrowed or obstructed. And it's a nice procedure in that it doesn't involve any incisions. It's not open surgery. It usually doesn't even involve general anesthesia. You don't have to have a breathing tube put down for this procedure most of the time. And what we do is the valve is essentially folded up on a delivery system, and it's inserted through the arteries in the leg most commonly, and we're able to insert it up into the heart and through the native valve in that fashion. Now, there are certain patient characteristics that make someone eligible or, you know, maybe not as good a candidate for that procedure. We also have procedures involving minimally invasive surgery that use smaller incisions, but it's still open heart surgery where we actually remove that blocked valve and we manually sew in a new valve. And then additionally, for other types of problems involving the mitral valve, for instance, we frequently try to repair the mitral valve instead of replacing it. And we will also use both endovascular or catheter-based technologies to do that sometimes, depending on, again, patient characteristics that involve no incisions and just using those needles and catheters, or open surgery. And there's also robotic surgery or minimally invasive surgery available for that type of procedure. So like I said, there's a lot of different things we can do, and it really just depends on what is best for the patient. It becomes a discussion amongst the team and the patients together.
It's good to know. I'm glad that there's a team approach and it's more collaborative, and you involve the patient as well in their treatment plan. So that's good to know. Also, Dr. Cohen and Dr. Wong as well, could you share any major advances in treatment for heart valve disease that have happened in the past 10, 15 years?
Sure. It's a lot to encompass. John, do you want to take this one?
Yeah, sure. Well, I think if we back up a minute here, it is remarkable to go back to something Dr. Sattler said. You know, the heart, when we think about it being a pump and pumping 100-some thousand times a day, and people living the average age of 78 years, it's amazing that as an organ made of tissue, that it lasts as long as it does, and that we don't see more of heart disease. And these valves, these one-way valves, these 4 valves in the heart made of tissue work for almost 8 decades. And when you think about it from something mechanical, a machine, we don't really have engines that run smoothly for 80 years. And it really is remarkable that they last as long as they do. In addition to these 4 valves that we've been talking about, Dr. Sattler made the point that they're either stenotic or regurgitant. They're either don't open well or they're leaky. The other thing that makes this complex is that you can have problems with multiple heart valves at one time. And sometimes one heart valve being leaky or tight leads to another one to dysfunction because these are in sequence. So it's very complex, and that goes back to Dr. Cohen's point about having a team approach to make sure that we have the right approach. And sometimes this requires joint procedures, ones that are invasive and surgical, and then we pair that with one that is catheter-based and to come up with the best solution. In the last decade, not even quite 1 decade, transcatheter valve technologies have just exploded. So just to take aortic stenosis, which is a very common problem as we get older, where calcium builds up on this aortic valve and it doesn't open, and patients get severe symptoms. Prior to 2012, when they were actually FDA approved in the United States, the only way to replace that aortic valve was with open heart surgery, traditional open heart surgery. So incision, a median sternotomy, placing the patient on a heart-lung machine, taking out the old heart valve and sewing in a new surgical valve. That was what was done traditionally, unless you were part of a clinical trial prior to 2012. Subsequently now, not even 10 years later, just about 10 years later, we are rarely doing that procedure and mainly replacing the aortic valve with a catheter-based procedure. And like Dr. Cohen was saying, this is a heart valve that's crimped or mounted onto a catheter that's about the size of a number 2 pencil. It's inserted into an artery in the leg, and it's actually deployed inside of the old calcified valve and pushes that one to the outside and uses the calcium on the old valve to hold on to the new valve. And this procedure takes under an hour. The recovery is also much faster for these patients, and they go home usually the next day. So the advances that have occurred have been one where we're really going towards a less invasive approach to try and fix these valves, one of miniaturization of all of our technologies that we have to make it a faster and safer and more effective procedure for our patients. So I would say just using that one example of a therapy for aortic stenosis that certainly during my training had only option of traditional open heart surgery, and one now where over 90% of these, if not more, are done catheter based, is a remarkable revolution in the last decade.
And thank you, Dr. Wong. I think in talking about those treatments and those advances along the years, I think that's a good segue to a few of the audience questions that we received. So thank you all for tuning in and sharing your comments and questions with us. I have a few questions that I want to direct to the panel. So my first question is from Joanne. She's asking, is it still necessary to take amoxicillin prior to dental appointments if you have mitral valve prolapse? Does anyone want to tackle that question?
So the recommendation, if you have a heart murmur or underlying heart valve disease, is for antibiotic prophylaxis for dental procedures. If you're not allergic to penicillin, amoxicillin 2 grams, usually 4 pills, about a half an hour before you go see the dentist, is still what's recommended. When we are done fixing heart valves, either surgically or with catheter-based procedures, the formal guidelines is that you still continue what we call endocarditis prophylaxis, these antibiotics to prevent an infection of the heart valve when you have dental procedures, but only for 6 months. And in our practice, we actually feel that that may be a little bit too quick to not take antibiotics before you go see the dentist, because really 4 pills of amoxicillin before seeing a dentist will hopefully prevent any infection on your new heart valve or your diseased heart valve, and the risk is fairly low. If you develop an infection, it can be catastrophic. So in our practice, we recommend after heart valve surgery, either done traditionally or with a catheter-based approach, or if patients have underlying heart valve disease, to take it for longer. So in an ideal situation, before every time you go to a dentist, but for minimum 1 year after a procedure.
It's a good point that you make, John, because I think a lot of patients don't appreciate that a TAVR valve is really a heart valve. And because the procedure is so quick and the downtime is so little, they often have dental procedures without prophylaxis. You just need to tell your provider that you have an artificial heart implant, and then they'll decide, depending on what they need to do, whether or not prophylaxis is indicated. But anytime you're at high risk or there's any kind of dental work, it's probably smart to get prophylaxis.
Thank you. Thank you, Dr. Wang and Dr. Sattler. I have another question from Judy. She has had a TAVR for an aortic valve in July 2020. She said the results were amazing, but I never had pain. I do have occasional AFib now, often triggered by indigestion. Usually famotidine and Tums will check it or resolve it. I never had AFib before the heart valve problem. Is this common?
So in the aging population, it is more and more common to see atrial fibrillation. It's probably not related to the valve itself, but if you are having episodes of AFib, it's good to get a provider involved, because in some cases, because of the duration, you could be at risk for stroke. And so it's worth talking to the providers that are taking care of you to make certain that you're being appropriately treated. In some patients with paroxysmal atrial fib, we may recommend long-term anticoagulation. So a lot of it depends on something called a risk score or a CHAS risk score as to whether or not there would be a benefit of long-term anticoagulation.
Also worthwhile probably at one point, in addition to discussing with your general cardiologist, potentially even seeing an electrophysiologist, cardiologist that specializes in atrial fibrillation and other arrhythmias. Just like today, we're talking about heart valve disease and the advances, there are remarkable new therapies for atrial fibrillation that are include, of course, medications, and even catheter-based procedures to completely eliminate your atrial fibrillation. When sometimes those fail, there are even combined procedures with our cardiac surgeons, and Dr. Bethay may be able to talk about some of those that can try and eliminate very challenging cases of atrial fibrillation to control with just medications. And we even have devices that are actually placed inside of this little outpouching of the atria that is where traditionally the blood clots form, which is what Dr. Sattler was alluding to, is what breaks off oftentimes in those patients at higher risk if they're not on blood thinners that could go to the brain and cause a stroke. So there are a lot of different therapies that are available, and it's definitely worth exploring. But I agree, it's probably unrelated to the TAVR valve, two very common problems.
Yeah, so I'll just real quickly just make a comment because I don't want to get too far away from valvular disease, but 1 out of 5 Americans over the age of 65 develop atrial fibrillation. And for the patient who asked the question, it's important to be evaluated because the potential to restore you to sinus rhythm, the sooner you're seen and evaluated, the higher the chances. And you can avoid the advanced maneuvers that John was talking about with myself and an EP cardiologist. So I think the next step for you is to see your physician and let them know.
Thank you all for sharing your responses. I have another question from one of our audience members. This one comes from Wendy. She says, what can you do for a small leak in the aortic valve?
So there are a variety of things we can do for a leaking aortic valve. And it depends on a variety of things. It depends whether this is a leaking surgical valve, like if a patient's already had surgery or even a TAVR procedure and there's a leak around it. Sometimes we can fix that leak using catheter technology, again, without having to do open surgery. Sometimes the leak is small enough that you don't have to do anything. Again, we're always measuring the risks and benefits of doing a procedure. But if the leak is severe, and like I said, it depends on a variety of factors, we could try to fix that with a catheter. If it's a leaking valve, a native aortic valve where a patient hasn't had a previous procedure before, there is a special kind of TAVR valve that we do utilize here for appropriate patients. It's in a trial to address that specific problem. And then, of course, surgery is always an option in terms of fixing a leak. A lot of times that means, again, replacing the valve, but we can almost always address a leak with surgery.
When a small leak probably wouldn't need to be addressed. I mean,
Right.
The things that we're looking at is larger leaks. That's number one. Number two, are you having any symptoms with the leak? And then number three, how is it affecting the heart muscle performance? If the heart muscle is showing a reduction in its contraction, then many of the options that Jeff have alluded to are in play, from repair to replace. And so we're very careful about the terminology of small, medium, and large and how it affects the individual.
And we have another question from our audience member, Judy. She's asking another TAVR related question. She says, is it true that TAVR lasts 10 to 15 years?
Well, we don't know that yet because even though the first TAVR was implanted nearly 20 years ago, believe it or not, in this spring, it's going to be 20 years anniversary to the first TAVR. It was started in a very elderly population and very sick population. So their duration of life was not that long. Now, in the past few years, we did move to low-risk patients and younger patients. And now we are implanting those in 20 and 60 years old and maybe even younger than 60 years old. But we don't have the longer duration follow-up. But as much as we can tell, the duration of the TAVR is as good as surgery. There is really no data to show that there is any inferiority, and there is data up to 8 years. So I can tell you that over the years, we know that 8 years, there is no difference, but usually the duration or durability of a TAVR valve is over 10 years. So we do have to wait a little bit to see which one lasts longer, but we do not have any signals or signs that with TAVR we have shorter duration. And actually there are some hypotheses that it would may give you a longer durability.
Great, thank you. Thank you, Dr. Waxman. At this time, thank you all again to our audience members real quick. Thank you for tuning in and sharing your questions with us. If you have any more questions or comments along the way, keep on sharing those with us. But at this time, I'd like to turn back to Dr. Wong and ask about any clinical trials that are underway.
Thanks. So the MedStar cardiovascular system, the Heart and Vascular Institute, has a large clinical research organization called MedStar Cardiovascular Research Network. And we have, I think it's over 175 ongoing clinical trials in the organization. It's spread throughout the Baltimore and DC area, and we have many, many trials that involve the various different heart valves. And these trials range in the aortic valve from the newer valves that are newer model valves that are being developed and we are a part of, as well as what Dr. Cohn alluded to, not just research looking at stenotic valves or ones that don't open well, but ones that are particularly leaky. And that is a unique valve called the Yenna valve that is being studied as well. So in each of the particular areas, MedStar, both in hospital center and Union, we are participating in the next generation of devices. And the best way to think about this is that every medical device, in order for its approval to be used and to be approved by the FDA, has had to undergo a clinical trial. And what these clinical trials do is it allows patients to have access to technologies that have been in development that will most likely be the future technologies used, but to have access to them before they're fully approved. Many of the trials that we're involved in are in devices that have already been approved in other parts of the world, such as in Europe and in Asia and Australia. And we are participating in their large pivotal trials in the United States to gain US FDA approval. We also have exciting trials in the mitral space. The mitral valve is a much more complex valve than the aortic valve. And we have a trial where three different trials where we are able to replace the mitral valve completely. One of these is actually done through a small incision in the side of the heart, and a catheter is placed through the tip, and that's what's called a transapical approach. So not completely non-invasive, less invasive, but through a small lateral thoracotomy. Then we also have two other trials where we're actually able to thread a catheter in the vein in the leg, cross from the right side of the heart to the left side of the heart with what's called a transeptal puncture, and deploy a brand new mitral valve without traditional open heart surgery. So evaluating two different technologies. So there are a lot of exciting trials, and we have not spoken much about this, but we are also working hard on the tricuspid valve, which is oftentimes the forgotten heart valve. And the reason why people have not talked much about it in the past is that there have not been good therapies for the tricuspid valve. And the tricuspid valve, predominantly the pathology or the problem with it is that it can be very leaky and cause people to have a lot of swelling in their legs and feel bloated and retain water. And when that happens, there are technologies now, we're a part of a trial that we're actually able to place a little clip that pulls the two leaflets together that reduces the leakiness of the tricuspid valve. But there are also future trials in the works where there is a complete replacement of the tricuspid valve, again, through a catheter without traditional open heart surgery. So there are a lot of exciting trials that in the MedStar system you have access to. Again, what I like to tell patients, tomorrow's technology today, so to speak.
I like that. I like that. It's good to know all of the wonderful things that are happening across the system at MedStar Health. Thank you very much, Dr. Wong. At this time, as we close, I'd like to turn to Dr. Waxman. What advances in heart valve disease treatment are on the horizon?
Thank you. I mean, I think a lot was already alluded by Dr. Wang, but I would say that in general, we're looking on two main topics. One is lifetime management of the valve. We'd like to make sure that we can provide the valve to younger, healthy patients, and it's going to be one-time intervention, which is very challenging. So on the horizon, we do have different materials of valves. Some of them are synthetic, that presumably, based on animal studies and bench studies, they can last for many, many years, more than the regular valves that we have been using, the bioprosthetic valve, and they're probably durable as the mechanical valve that we try to stay away from them. So that's like one direction, make the procedure durable, whether it's a repair or replacement. The second aspect of looking forward is how to continue to minimize the intervention, to make it less and less invasive, or using small size catheters. So that would be associated with the very fast healing and give you much more options. In general, we're trying to stay away from sternotomy if possible, or major surgeries, and we don't see that as a competition. We work today hand in hand with the surgeons, and they actually seems to like to do more the percutaneous approach than just to do the open heart approaches. So what we are seeing in the future, an array of devices, and it's also, the analogy is like, we're not driving any more than 1950 cars or the 60s cars. We want to drive the 2020 cars, right? The Tesla kind of cars. So the device technology is not stopping or halting. It's continued to iterate. And what's unique about the MedStar Health system, because of our size, we are attraction to all the companies that provide the new technologies. Again, we don't have the time to go over all of them, but I would say if there is something new, we have it. There is not a new device that right now being tested in the US that we are not part of the study at the MedStar Health system. So that gives us really a good opportunity to give first device to our patients in the area, and also to learn ourselves how to improve not only the devices, but the technique, because some of them are technique related. So overall, what you should look over time is getting better devices, more durable devices, requiring less invasive procedure, and in the future also some monitoring how those devices functioning in your own body. So a lot of exciting things are coming.
Thank you very much, Dr. Waxman, for sharing that. It's good to hear that a lot of things are coming down the pike in terms of heart treatment and valve disease treatment. So thank you very much for sharing that. So that wraps up our broadcast for today. Thank you very much for tuning in and sharing your comments and questions with us. If you have any more comments or questions, feel free to share those with us in the comments below. The next event in the Valve Disease Day virtual conference that we're a part of is the annual Twitter chat. So this year's chat is co-hosted by the Valve Disease Day campaign and WebMD, and will focus on the impact of the COVID-19 pandemic on the diagnosis and treatment of valve disease. So if you'd like to learn more, you can follow that chat on Twitter using the hashtag Valve Disease Day, all one word. We'll provide that as well in the comments for you below. So tune in for that, and the chat will promptly begin at 1 p.m. So keep your eyes peeled for that. And thanks again to our panel for joining us. Doctors Brian Bethea, Dr. Jeffrey Cohen, Dr. Noel Sattler, Dr. Ron Waxman, and Dr. John Wong. Thank you very much for your time and for sharing your expertise with us. We'll see you next time, everyone.
Thank you, Mashan.
Thank you. Thanks.
Thank you very much.